Hi everyone, thank you for joining us at this moment for this discussion, most interesting topic of immunotherapy. I'm Wilberto Nieves Neira. I'm one of the associate professors for the Feinberg School of Medicine with Northwestern University, attending physician for the Division of Gynecologic Oncology under the Robert H. Lurie Cancer Center. And within the division, I serve also as Associate Director for the Fellowship Training Program in Gynecologic Oncology. So on this occasion, we're going to talk about immunotherapy as one of the most exciting areas of development and truly a new frontier in the therapy for cancer and how this applies to GYN cancers. In terms of our objectives, we want to understand the immune pathways that are being exploited in the new type of immunotherapy field to elicit a true anti-tumor immune activity, rather to unlock that immune activity, as we are going to show the details. We're going to understand the interplay between the tumor mutations and the tumor immunology mechanisms. And number 3, we're going to discuss early clinical trials of immunotherapies in the field of gynecologic oncology, or malignancies, and we'll discuss briefly some of the 2 trials that we have developed on our own here at Northwestern Medicine. In terms of disclosures, no financial disclosures to mention. We will discuss chemotherapy agents that have not been labeled by the FDA or approved by the FDA for the use in gynecological malignancies, but they do have indications in the treatment of other cancers, and I will tell you specifically which ones those are. Also, this presentation is with the purpose of education, so it should not be utilized as a comment or a recommendation for specific treatments or management of patient circumstances or diagnosis. In terms of gynecological malignancies, these are estimated deaths for women. These are the estimates for 2016. And we can see that in position number 5, we had ovarian cancer with about 14,000 deaths. That represents about 5% of women that die from cancer in the United States. And that's closely followed by uterine cancer. And together they constitute 9% of deaths in women. So from that point of view, right, our GYN malignancies still constitute a good segment of our patients that are dying from GYN malignancies. In terms of ovarian cancer in particular, which is the most lethal GYN malignancy that we have to deal with, there have been an evolution of survival as well as treatments. And the question is, where do we go from here to really make the most impact? So on this lower column, we are referring to basically a timeline of the basic chemotherapy that we have used for ovarian carcinoma. Basically, the modern era starts in 1985 with the addition of cisplatin, and then by 1996, the New England Journal publication that established cisplatin and paclitaxel as a breakthrough with extension of both progression-free survival as well as overall survival. It was only 6 months, but in those days, that was a major improvement in survival for our patients. We moved into the early 2000s where we were able to show that carboplatin can substitute for cisplatin in combination with paclitaxel. And then in 2006, the publication of intraperitoneal chemotherapy, which has been one of the strategies that offers the longest survival for women. Where do we go from here? So we can continue to explore the avenues of traditional chemotherapy, intraperitoneal chemotherapy with different regimens, and dose-dense chemotherapy that has made a major impact and is being used more and more. In the patients that are really compromised to undergo surgery, the concept of neoadjuvant chemotherapy reduces the tumor burden before the actual surgery, so we don't have to do such a radical debulking surgery. Then the 2 areas that present the most promise is the area of PARP inhibitors. And we have seen 3 approvals by the FDA in the last 6 months for the use of PARP inhibitors in recurrent ovarian carcinoma. Then the other area that we're going to be concentrating today, which is the targeted therapies. Now, I want to put this within a framework, and that is a concept of personalized medicine that does not apply only to cancer, but to general medical care. Within that frame, then we have our biological therapies, so we can target some specific pathways within tumors, but we don't individualize necessarily to each particular patient. Then the next step is to move into the targeted therapies, where we are able to identify more specifically particular mutations or pathways that we can target specifically. And then we move into the third dimension, which is really nowadays where we're able to make a lot of progress, which is the concept of precision medicine, where we can apply therapeutic interventions that are very specific to the tumor of one particular patient based on the mutation profile of that particular tumor for that particular patient. Within this precision medicine, we have three domains. One of them is mutations, and we have made a lot of progress in this area as it becomes much easier by next generation sequencing to identify the mutations that harbor, the tumors harbor. The concept of immunomodulation, so this is the modern era of immunotherapy that we're going to be expanding briefly now in today's talk. And then the concept of epigenetics, so these are changes that happen afterwards and that can lead to silencing or activation of different genes. Within this realm of precision medicine, we still have an interconnection with the more traditional cytotoxic agents, and most of the therapies actually combine this therapeutic precision medicine agents with more traditional cytotoxic agents. And we are learning also that some of these cytotoxic agents can be used more specifically as part of the precision medicine as we learn more about the mutation burden. In terms of further developments, right, and the Cancer Moonshot Initiative for 2020 was announced, and the original intent of the Cancer Moonshot was really to move and understand better the immune aspect of tumors. And of course, after that, it has been expanded to 16 different areas within cancer research. But the idea is to have a consortium between government, industry that can work together to further the cause of research and make developments much more rapidly, with a stated goal of aggressive focus on developing new treatments for cancer. And the idea would be that we want to have these strategies, right, by the year 2020 to be fully developed. So it's an acceleration of our research goals. The original intent, again, was based more on the immune system, but that has been expanded. In terms of immunotherapy, for example, a lot of developments very recently. It was considered to be the breakthrough of the year cancer development in 2013 by Science magazine, one of the most important magazines for new developments in science overall and medicine and biology and so on. So already on the forefront of science. And the basic idea is for us to be able to manipulate the immune system in such a way that we can allow these cells that are already present surrounding the tissue, but they are inactive. So we had to find a way to activate them so now they can engage the tumor and destroy those tumor cells by the regular classical immunological pathways, just as our immune system is able to get rid of bacteria and so on. Okay. The early days of immunotherapy were mostly based on a traditional vaccine approach, and they didn't get us too far. So just to summarize what we were doing, we would have a patient with metastatic disease or recurrent disease. We'll get a chunk of the tumor and then take that to the lab. We would do tumor extracts, get some of the peptides, proteins, or DNA. These were different approaches to try to find what were the antigenic determinants for that particular tumor. We would inject those in animals and then develop the vaccines. And then we would go back to the patient with the use of vaccination strategies, maybe adjuvants or the administration of cytokines like IL-2, and then try to elicit immune response that way. The goal, activation of the immune system response, using the concepts from adaptive immune response to viruses or bacteria. Okay? Now, as our knowledge has progressed, we have gained a lot of new insights as to the complexity of T cell activation. So we know that there are different aspects of this process. We have activation, proliferation, functional differentiation, inhibitory pathways, and within that, there are areas of co-stimulation as well as co-inhibition that are very important and relevant for a full immune response. So let's talk a little bit about T cell TCR function. Right? So this is the classical way that we have learned to understand TCR and T cell receptor function in college or, for example, my early days in medical school. We're not going to say how many years ago, but not that many, right? And what we have is the antigen-presenting cell will uptake an antigen from bacteria, parasites, in this our case is tumors, that will be processed within this cell. It could be a Langerhans cell, it could be a dendritic cell, and it's going to be presented to the T cell in the context of major histocompatibility complex molecules, MHC, and with the antigen. That's going to be presented to the T cell receptor. If the context of presentation is within MHC class 1, we're dealing with CD8 cytotoxic T lymphocytes. If it's presented in the context of MHC2, then it's a CD4 T helper context. Now, what we have learned is that it's not just that MHC complex, there are many other molecules that are going to be present in both sides of the equation between the antigen presenting cell as well as the T cell itself. Okay? So here we have the classical understanding, in this case a class 2 MHC molecule, TCR presenting the peptide, which is the antigen. Okay? Then we have signal transduction, which are mediated by a number of molecules, adhesion to facilitate the interaction between those two cells, and so on. So there are many other players in this interaction. Okay? And what we have learned is that at least you really have or require 2 signals to be able to activate those T cells. So the APC here on the left, you have your traditional T cell receptor, and then in order to have stimulation, that's going to be mediated through the expression of a molecule B7. In the T cell, the counterpart receptor is CD28. And that's going to lead to a positive activation and proliferation of the T cells, and therefore moving forward with the immune response. So on the APC side, the ligands, B7, 1 or 2, for the antigen-presenting cells. We can also have B7 present, and then PDL1 or PDL2. On the T cell molecule, we have CD28 that will bind with B7, and that's co-stimulation signal. But if instead of CD28 we have CTL4, it's going to be the contrary. It's going to be a negative regulation and inhibition of that interaction. The same thing happens between PDL1 and PD1. There is a negative regulation. So these are what we call the checkpoints in the T cell activation process, and this is what most of the modern immunotherapy agents are trying to target, is to free up these inhibitory signals that are present there. Okay? So we have come to learn that tumor microenvironment is immunosuppressive by itself. So for many years we have known that many of these tumors are infiltrated with lymphocytes and macrophages and all that, but they're not really doing anything, they're just standing by. And we have come to understand why. So the tumor cell can have learned to bypass or use some of these molecules to elicit that immune inhibition process. So for example, one of the mechanisms is lack of expression of this B7 molecule by the tumor cells would then render the tumor invisible to the immune system. So that's what we call tolerance, right? Because there is not going to be, it's an inhibitory signal, there's no proliferation of these T cells, lymphocytes. Or the tumor can then express, for example, PD-L1, the ligand, and then bind to PD-1 in that T cell, and again, that's going to be inhibition. So it is not really invisible to the immune system. There's recognition, but that recognition leads to an inhibitory signaling and no activation of the immune system. Now, of course, the immune response is much more complex than that. So within this context of micro environment being immunosuppressive, there are several other players. So that's what we are depicting in this cartoon for anti-tumor immunity. So the cells are going to be present in the tumor. Antigen presentation is going to occur to the regional lymph nodes. Here in the lymph node itself, we can have T cell activation. Those are the cells that are released and then come back into the tumor. But if the tumor is expressing PD-L1 and the T cell has PD-1 present, that binding will then render the T cell inactive. In addition to that, we have these other T cells, lymphocytes, the Tregs, regulatory T cells, that are also going to inhibit that immune response. So if we're able to learn how to take away this break, then we'll be able to elicit an effective immune response against the tumor, and that's what we have learned to do so far. So how do we do that? So the removal of this inhibitory pathway that actually is blocking in a very effective way the anti-tumor response is to use antibodies that will bind to those checkpoint molecules and therefore render not functional. So the antibodies that we have at this point in time, CTL4, PD-1, PD-L1, and those are the different medications that we're going to be addressing. So this is the general concept. So in this case, we're talking the interaction between B7 and CTLA4, which is inhibitory. So if we put an antibody that will bind CTL4, then it displaces B7, and we take away that inhibitory signal. So now we have a go-ahead overall signal by having CD28 being free and then preferentially binding B7 to CD28. So this is ipilimumab. That was one of the very first agents that was FDA approved and tested for metastatic melanoma. In the case of PD-1 inhibition, we have pembrolizumab, and the same concept. We can disrupt this negative interaction by displacing the molecules with the antibody, and then anti-PD-L1, the ligand, nivolumab, avelumab, atezolizumab, can achieve pretty much the same goal. Okay? So there have been literally a revolution in this area, particularly in the treatment of metastatic melanoma as well as non-small cell lung carcinoma. And we have seen a slew of succession of FDA labelings and approvals in the last few years. We started with melanoma, ipilimumab approved in 2011, then pembrolizumab 2014, nivo that same year. For non-small cell lung carcinoma, nivo was approved in March of 2015, pembrolizumab that same year, and then atezolizumab in October of 2016. Renal cell carcinoma, we had an approval already for 2015. Colorectal cancer, that is microsatellite is unstable, is going to be pembrolizumab, and that's for November of 2015. Urothelial carcinoma, that's another area that for more than 30 years there have been no particular drugs approved or really effective against metastatic urothelial carcinoma. Nowadays we have 2 approvals already, atezolizumab in May of 2016. Just very recently, Nivo was approved also just 2 months ago in February of 2017. And durvalumab was just approved in February as well, was FDA granted priority review status, so we expect that that's going to happen very soon. Even in the treatment of more conventional type lymphatic system tumors, Hodgkin lymphoma, Nivo approved in 2016 and Pembro in March of 2017, so that just happened a little less than a month ago. So a lot of rapid development here. Head and neck cancers, pembrolizumab for August of 2016, Nivo followed very closely in November, and then one of the very latest approvals for Merkel cell carcinoma with avelumab in March of 2017, a disease that really we don't have not had any good treatments for a very, very long time. So again, we have seen an avalanche of approvals, and we're very excited in GYN oncology because we're pretty sure that we're going to be able to utilize these agents with achieving very good results. So how can we get there, and what other aspects are going to be very important and relevant for these immunotherapies? So here is the concept of neoantigens that becomes very relevant. So you need to have an antigen that has to be recognized by the immune system. So this concept of neoantigens is very important and has been correlated with the potency of the immune checkpoint inhibitors. So the antigens are needed for the mobilization of the endogenous T cells. So the implication is that the endogenous compartment of T cells is able to recognize peptides or epitopes that are actually displayed by the surface of the tumor cells. So this is in vivo situation, right? The neoantigens are the peptides that are absent from a normal human genome, and they're going to be tumor specific because they are related to the particular mutation of that particular tumor. And because of that mutation, we have a novel protein that is being present or sequenced, and that's where the concept of neoantigens becomes important, so we can avoid some of the toxicities of earlier therapies that were also attacking some regular tissues because some of the proteins were shared. So the pool of T cells that are reactive against these neoantigens is not going to be affected by central T cell tolerance. They're going to be tumor-specific and patient-specific. So in the global scheme of things, again, precision medicine goals that we all want. So we have been able to correlate that the number of somatic mutations correlates with these so-called neoantigens. And here we have a graph going from least to most formation of neoantigens. And no surprise that the tumor with the most number of neoantigens is melanoma, and that was the tumor that was first studied and where we really made a big impact with immune checkpoint inhibitors. Then that's followed by lung cancers, and that was the second disease that really have literally been revolutionized with the use of these agents. In terms of GYN oncology tumors, GYN malignancies, we have uterine cancers, particularly the ones that are MMR, mismatch repair genes deficient, have a moderate amount of neoantigens, followed by cervical cancer, and ovaries actually on the low to moderate side. So we would expect to have better responses in uterine cancers. But the main idea is that the more neoantigens are being present, correlate with the somatic mutations being present in the tumor, and we can easily sequence those mutations nowadays. Okay? The second idea that is very important, and this is a paper that even made it to Science, even though it's a clinical paper, is that this mutational landscape can really determine the sensitivity to the immune checkpoint inhibitors. In this example, is going to be PD-1 specifically, and the blockade of PD-1 in non-small cell lung cancer, where we can see that those patients, and we have here on the left the total exome-based mutational burden. So, and then here we have responses. So in those tumors that have the highest mutational load, therefore the highest number of neoantigens, we can see a concentration of the best responses being present with durable clinical responses being present. So DCB stands for durable clinical benefit. So that includes the parameters of partial responses or stable disease being present and lasting for more than 6 months. And again, that's what we can see here, that the higher mutational load, the better the responses that are going to be clinically relevant, even lasting more than 6 months. As that mutational burden goes down, then we start to see more of the red lines or columns, which means that there have been no responses or not durable benefit for those patients. So it's a very important concept that was proven in the clinical arena and give us the impetus to move forward. Moving into the future is even more exciting. So DNA sequencing that can be done pretty quickly nowadays and for a fraction of the cost even from 5 years ago leads to the identification, and we can actually predict what are going to be those neoantigens that are physiologically relevant, that are going to be present in that surface of that tumor. So thanks to a lot of the in silico technologies that we have nowadays, looking at non-synonymous somatic mutations, again, we can sequence those tumors and start predicting what are going to be the sequences that are going to be truly antigenic in the neoantigen sense. And with that, we can actually construct our neoantigen-based therapies, and we may not necessarily have to go back to the tumor to try to find out what are those determinants for that particular tumor. So with those concepts, we're going to move forward into our field. We are really in the infancy of development for immunotherapies and immune checkpoint inhibitors in particular in GYN malignancies, but a very important area. So the first one is endometrial cancer. And we know that between 30 to 40% of endometrial cancers are going to have a high mutational burden because of MMR deficiency, mismatch repair protein deficiency. So this was the trial of mismatch repair deficiency tumors and PD-1 blockade with pembrolizumab. Most of these patients were colorectal cancer, where MMR deficiency is very frequent. And there were a few endometrial cancer patients. So we had this forest plot looking at their responses, this being the best response. 2 of these 3 patients were actually endometrial cancer patients that were MMR deficient tumors. So very exciting to see that these endometrial cancer patients were some of the best responders. Looking at TCGA data and the molecular landscape of endometrial cancer, we have learned to reclassify or have a molecular classification for endometrial carcinoma. And we have 4 subgroups that can be identified. The first one is POLE, polymerase epsilon mutated tumor. So this is the ultra mutated phenotype, and that represents about 30% of endometrial cancers. Then we had the MSI, microsatellite instability group, and these are the so-called hypermutated endometrial cancers. And then we had copy number low. Most of these are endometrioid tumors. And the copy number high, most of these are type 2 endometrial cancer, serous endometrial cancer, clear cell carcinomas with a very poor prognosis. When we look at survival, what we can observe is that this molecular classification correlates with survival in a very striking way. So those tumors that are ultra-mutated phenotype because of polymerase epsilon have the best survival, and that's going to be followed by the group of hypermutations, MSI high, and as expected, and as we already know, those tumors that are high-grade type 2, serous type endometrial cancers have the poorest prognosis. Yeah? The POLE mutations, ultramutated phenotype, represents about 7% of endometrial cancers. The microsatellite instability is about 30% of endometrial cancer. So we can see here that these two groups, we can impact a big number, a big proportion of potential endometrial cancer patient responders. So looking at these questions, yes, we can say, and we know, that ultramutated POLE and the MSI positive endometrial cancers have a high number of neoantigen load, as well as tumor infiltration with CD3 positive, as well as CD8 tumor infiltrating lymphocytes. So that's what we see here in this graph, looking at the neoantigen load that was predicted, much higher and statistically significant for POLE, as well as for MSI tumors, compared to MS stable tumors. Infiltration of CD3 tumor infiltrating lymphocytes higher for the ultramutated phenotypes, as well as the infiltration with the CD8 cells. So we know that these cytotoxic cells are being present at higher numbers in the ultramutated phenotypes, and that's why we depict here the authors in terms of looking at the infiltration. So, this MS satellite stable tumor, so no significant infiltration or any at all. And the ones that are MSI positive or POLE mutated, that we have a significant infiltration with this relevant infiltrating lymphocytes. Okay. There's a high frequency of expression of PD-1 in this POLE or MSI positive endometrial cancer cells, as well as the tumor infiltrating lymphocytes. So this means that that molecular target is being present there. So in addition to that higher neoantigen load that was predicted, we can prove that the target of the drug is present. So we look here at PD-1 expression is going to be present both in the intraepithelial component at a significant higher rate for the ultramutated phenotype, as well as the peritumoral component, which is that microenvironment, those tumor infiltrating lymphocytes. When we look at PD-L1, this is a ligand expression, is significantly higher in the immune cells, that immune stroma. In this particular study, the ligand was not overexpressed in the tumor cells themselves. But if we're able to disrupt the interaction in the immune cells already, then that should lead to an actual clinical response. Yeah. This is another study that brings further elucidation into this question. And PD-L1 expression, specifically in tumor cells, as well as that peritumoral stroma. And we're looking at those MMR deficient tumors, mismatch repair genes deficiencies. Retrospective analysis, 67 tumors, of which 29 were MMR intact and 38 were MMR deficient. Within this 38, there were 20 patients that were actually Lynch syndrome, inherited mutation present, and then 18 that were MLH1 promoter hypermethylation. So this is an epigenetic phenomenon. So the silencing of the MMR proteins occurs after birth by different mechanisms. The assignment to Lynch syndrome was based on loss of expression of MLH1, PMSS2, MSH2, and CIS. And they were looking at the expression of the PD-L1 ligand in the tumor cells, as well as what they call the peritumoral compartment or the immune stroma. Just to remember why it's important that we look at this. So the interaction between the T cell and the tumor cell is going to be based on the expression of PD-1 into that T lymphocyte and the PD-L1, the ligand in the tumor cell. So if this is present, then we have inhibition, and therefore we can target those molecules with our checkpoint inhibitor. So looking at this target is relevant. Okay? Going a little bit further into the analysis, what we see, looking at tumor cells versus immune stroma, in those tumors that are MMR intact, the expression was 10.3% in tumor cells, 65% in the immune stroma, and most of these were actually minimal expression for the immune stroma, compared to 53% on the tumors that were MMR deficient, and all of the tumors had significant expression in the immune stroma, being statistically significant. So again, pointing that this target is particularly present in the MMR deficient tumors. Looking specifically into Lynch syndrome patients, we have a representation here, H&E regular staining of the endometrial cancers, an example of the expression of PD-L1 in the tumor cells present in the cell membrane as expected. And here, just to depict the infiltration of the tumor, so that's the microenvironment of the tumor. In terms of the proportion of expression, in the patients that have MLH1 hypermethylation, so this is the epigenetic phenomenon, 1/3 had significant expression in the tumor cells. All of the stromal cells had expression. But in those patients that were Lynch syndrome, the rate of expression went up to 70%. Still at the stromal component, we have 100% expression. So what this is telling us that there might be a preferential response in those tumors that are MMR, but based on an inherited mutation. And that would be one of the predictions that remains to be proven, but definitely very enticing that we might even be able to have different type of responses between an inherited mutation tumor versus a mutation that happens later in life, usually by an epigenetic silencing process. Okay? So moving into the clinical arena here at Northwestern, we have a proposal that is moving forward for a phase 2 trial in patients with stage 3 or 4 recurrent endometrial carcinoma. The principal investigator being my colleague, Dr. Mario Pineda. And the proposal is to do the trial with the Big Ten Consortium with a projected accrual for 80 patients using the standard paclitaxel carboplatin plus the use of pembrolizumab every 21 days for 6 cycles with a primary endpoint of objective response rates. We'll look at secondary endpoints for toxicities as usual for a phase 2, and then correlative endpoints to analyze the information about mutational load of these tumors and the expression of the ligands and the tumor infiltrating lymphocytes and so on. So we're expecting that this should open very soon, hopefully within 1 to 2 months. Okay? Let's talk about ovarian carcinoma. In ovary, the story is a little bit different, but much longer. So we already knew many years ago that ovarian cancers are infiltrated with these lymphocytes. And Dr. George Cukors at the University of Pennsylvania was one of the pioneers in this area with a publication that goes all the way back to 2003. And what they were able to show is that about half of primary ovarian tumors have significant infiltration with the tumor infiltrating lymphocytes. That's what's demonstrated here with an N of 186 tumors, a very respectable N for this kind of studies. And we're looking here at the expression, for example, of CD3 lymphocytes. We mentioned them already in the case of endometrial cancer, being present in the stroma of the tumor. This is immunohistochemistry, so 55% of primary ovarian cancer has significant infiltration versus the rest that were 39% with minimal or no expression, or infiltration, I should say. And these numbers correlated with the presence of CD4 and CD8 lymphocytes being present. Moreover, they were able to already start showing that there were differences in survival based on the infiltration of these tumors by TILs. So those patients that had infiltrating lymphocytes had a better survival that's 55% of the patients studied, or tumors that were studied, compared to the ones that did not have intratumoral T cells being present. And we're looking here at both progression-free survival as well as overall survival. And they were able even to show that this effect is strong enough to even take away the effect of debulking surgery by itself. So regardless of the optimal versus suboptimal debulking or cytoreductive surgery, the patients that had intratumoral T cells did better, okay, compared to the ones that did not have intratumoral T cells. Right? Since the 1970s, one of the mainstays of management of ovarian cancer has been aggressive cytoreduction. And we know that patients that have residual disease more than 1 centimeter are not going to do as well as patients that have no residual disease or less than 1 centimeter. But the presence of these infiltrating lymphocytes can offset that itself. Okay? When we look at TCGA data in a more contemporary series, right, we can detect what we call an immunoreactive like gene signature that is associated with high-grade serous ovarian carcinoma as well. And this is the plot here where we have the differentiated like. This is our immune reactive type. And then when we look at survival, what we see is that the immunoreactive signature had better survival compared to the mesenchyme-like tumors. So again, pointing to the direction that these immune mechanisms are going to be important in ovarian cancer. Okay. So the PD-1 pathway, right, the blockade promotes tumor-specific T cell activation, elimination of tumors. So that's what we're trying to achieve with pembrolizumab itself. So we have discussed this already, so I'll move forward in this one. So are the targets present or not in ovarian cancer? And the answer is pretty much yes. So we have examples here of the expression of PD-1, PD-L1 in the cancer cells for primary ovarian tumors. When we look at survival, so the way this study was conducted, they did a tissue microarray, 215 samples, and looked at overall survival outcomes that correlated with the messenger RNA level from TCGA cohort. So the expression of PD-1 in the tumors or the expression of PD-L1, so receptor and ligand, was associated with a better survival. And combined as well, had those patients that had both expression of both the receptor or the ligand had the best survival. So this is looking now specifically at the targets being present. So in the clinical arena, there have been a number of phase 1 trials that have been carried. Anti-PD-1 therapy with nivolumab, 20 patients, overall response rate of 15%, but durable clinical responses of 45%. So that's important to highlight that this number is low, but the ones that are responding will have durable responses more than 6 months. Pembrolizumab, 26 patients, 12% response rate, 35% had durable clinical responses. For anti-PD-L1 BMS agent, 17 patients, 24% response rate. And avelumab with 75 patients, that's one of the largest phase 1 trials that we have carried in this arena, with an 11% response rate. And again, durable clinical responses, 55%, so that's important. So you may say, well, 15%, 11%, that doesn't really, that's not a great percent. Let's just remember that once we have recurrent ovarian cancer, most of the responses that we can expect from any of the long list of chemotherapies that we have available is anywhere between 10 and 20%. So this is well into that area. And if we take, for example, the case of bevacizumab, which is FDA label for the management of recurrent ovarian cancer nowadays, When we look at the phase 1 trial, GOG 170D, the overall response rate at that time was really 11%. And that's a drug that has become mainstay in the management for ovarian cancer. And the other thing is that this is the story also with melanoma. About 25% of patients with metastatic melanoma have had responses, and they are long-lasting responses. So we just need to learn how we can improve the fraction of patients that are going to respond either to these particular agents or find that combination of inhibitor that will be best for the other tumors. So this is actually very, very encouraging. This is a forest plot for the avelumab trial, recurrent ovarian carcinoma, 75 patients. These patients have refractory disease, so really they have very limited options and very unlikely chances of having meaningful responses. Of the 75, 51 had at least 3 prior regimens. Partial responses in 11 patients at 15%. When we start looking at the responses, these are the best responders here. We can tell that there are 2 of these patients, best responders, that were clear cell histologies. So this is an area that causes also excitement because there is really no chemotherapy that is particularly relevant or meaningful in the case of metastatic clear cell carcinoma of the ovary. So this opens a possibility that maybe this could be an avenue to pursue. We already have phase 3 trials on the way. Javelin Ovarian 200 GOG 3013 trial, randomized phase 3 trial with a projected accrual of 550 patients. It's a very, very large trial, as we normally do with our cooperative group trials. Platinum-resistant or refractory ovarian carcinoma, no more than 3 previous lines of treatment, and no prior therapy for platinum resistance, so it's mostly the platinum-sensitive group. Primary endpoints of overall survival and overall response rates. So we're randomizing 1:1:1, avelumab as a single agent, and Doxil or pegylated doxorubicin plus avelumab, and then Doxil alone as single agent and regular standard chemotherapy comparator arm. So we'll see what the results are going to be on this. When we look at ovarian cancer, and this is a karyotype of a patient with ovarian cancer, and we look at the actual mutational load, I already showed you that slide that showed there wasn't that much in terms of the mutational load being present. If we look at this karyotype, what we can realize is that ovarian cancer overall is a disease of massive chromosomal abnormalities, and there are many copy number changes, but there are actually few mutational events. The principal defects being present for DNA repair are p53 mutations and mutations on BRCA1 or 2. So how can that still translate into a relevant response and use of immune checkpoint inhibitors? What we have to remember, and this is an area of much more recent development, also another area that's very exciting, is that it's not just the BRCA1 or the BRCA2 mutation, it's the pathway itself or homologous recombination deficiency. So when we look at high-grade serous ovarian carcinoma, and we start looking at all the components of that homologous recombination pathways, we are finding that pretty much 50% of these patients with high-grade ovarian carcinomas have deficiencies on these pathways that will render BRCA1 or 2 mutation-like. So that expands the possibilities then of these mutational events. When we look at the HR-deficient tumors, germline or inhibitor mutations accounts for 8% overall. These are all comers. Followed by somatic mutations. So these are BRCA mutations that can happen at the tumor level alone, 3%. BRCA2, germline inhibitor mutations, 6%, and the somatic mutations of 3%. But when we start looking at the other pathways or components of the pathway, again, we can get up to about 50% deficiency being present. And also, MMR deficiencies are present in ovarian carcinoma, low rate of 3%, but we know that there are interactions between the pathways. So this is another area that still opens the window for the feasibility of using the inhibitors being present because of the interaction between the BRCA1 pathway and MMR recombination pathways. Yeah. So can we detect a differential immunophenotype in these BRCA deficient ovarian cancer tumors or not? Right? Are the targets differentially expressed for the presence of PD-1 or PD-L1? So looking at the tumor set of high-grade serous ovarian cancers, mutated tumors, 37 versus 16 in the wild-type BRCA group. Immunohistochemistry assessment for subsets of tumor-infiltrating lymphocytes and the expression of the agent and ligand and receptor, PD-L1 and PD-1. So what they were able to show, the authors, was that there's higher expression in BRCA mutated tumors compared to the wild type. So for a combination of CD8 and CD4 cells, p-value of 0.03, infiltration of peritumoral lymphocytes, 0.04, PD-1 expression in the infiltrating lymphocytes, 0.03, p-value, and PD-L1, 0.01. So we're seeing more expression on the BRCA mutated tumors. Now, in terms of PD-L1 expression, there was no significant difference in the expression at the tumor level. But again, if we have a differential expression in the infiltrating lymphocytes, we still have a chance that inhibition of the pathway could lead to an immune response. Then the last area to touch is, and I have alluded to this already, is epigenetics, so the changes that occur after we are born. They can happen at any point in time, and we're learning more and more about this. How these different situations can lead to silencing of genes in particular. So it's a DNA methylation process that for the most part is going to lead to the repression or inhibition of gene expression. So it would render the cells lacking the expression of these particular genes that are being targeted. Postnatal events, environmental factors, again, we're learning a lot about that. In terms of ovarian carcinoma, we know that we can do an epigenetic resetting using low-dose latinamycin that can resensitize the cells to recurrent ovarian cancer to platinum. And I should say it's not latinamycin, sorry, it's the acetylating agents. So we have a tumor that is recurrent platinum-resistant ovarian cancer. We can do a demethylation therapy, right? So reverse the effects of that epigenetic phenomenon. And the cells now can be chemosensitized again to the effect of platinum therapy and induce cell death. So this is the work that has been carried on in the lab of our own Dr. Daniela Matei with our Division of GYN Oncology at Northwestern Medicine and the Cancer Center. So we have an agent, SGI-1110. It's a new DNMT inhibitor from Astellas Pharmaceuticals. So it's the cytarabine that is rapidly eliminated by the cytidine deaminase. So this leads to decreased drug exposure to the cancer cells in vivo. And we can then use this analog, right, and protect the cells from the amination itself. So it's the inhibitor. So if we treat cells with the agent and carboplatin, Dr. Matei has been able to show that there is immune activation of different pathways that one way or the other have to do with the immune system, and they're listed here. But the point is that by doing this pre-treatment with the acetylating agent, we can then restore some of this immune activity against tumors. And this was a phase 1-2 trial, 104 patients, with SGI 1110 plus carboplatin versus standard chemotherapy, and they were able to show the change in the gene signature being present. So that has led to the current trial that is open to accrual here at Northwestern for platinum-resistant ovarian carcinoma, phase 2 open-label trial with a projected accrual for 38 patients, pre-treating them with wadacitabine daily times 4, then followed on day 5 by pembrolizumab, and we repeat this every 21 days. Primary endpoint, objective response rate, and she's performing correlative endpoints to analyze the methylation of PBMCs to make sure that the agent is doing what we expect it to do, and the expression of PD-L1, as well as the variations in infiltration of lymphocytes for the tumors. We're very excited about this. Just one more slide to say that we can find different ways to then sensitize cells to the effect of checkpoint inhibitors, and that's the case, for example, of OX40. So this is mostly in vitro laboratory data, but we already have phase 1 trials with OX40 ongoing, including here at Northwestern Medicine, the Cancer Institute. In an ovarian cancer murine model, for example, the cell line ID8 is poorly immunogenic in terms of once we have the formation of the tumors, and therefore there's minimal response to anti-PD-1 therapy. But if we treat the cells now with the OX40 inhibitor as well, then we can resensitize the cells to the anti-PD-1 therapy. So that's what we see here, that the mice that are treated, IP injection xenografts type model for the experiment, PD-1 inhibition, OX40 inhibition, these mice are dying quickly, but when we have the combination of both agents, then we have increased significant survival of the mice. Again, long-term survival is being present here, and that's what we also represent here in terms of mean survival time. That is significantly improved for mice where we're treating with both. So basically, the OX40 is taking away that lack of immunogenicity, so then that allows the action of PD-1 inhibition to take care of the tumors. So this is a very exciting area that we're exploring as well. For cervical cancer, that would be a different talk, as there are so many other different types of immune strategies that we can do for cervical cancer. It's a much more complicated story. So in summary, these novel immunotherapies are providing us with a powerful framework to elicit powerful immune system responses to fight tumors. Different tumor types will require different pathway manipulations, and the role of multiple co-regulatory molecules remain to be elicited and elucidated, and may be the key to specificity between different types of tumors. Correlation between mutations and the expression of neoantigens, as we have discussed. And definitely, there's no question that these immune checkpoint inhibitors, at this point in time, hold the most promise for defeating cancer in the foreseeable future. So with this, we'll conclude, and thank you very much for participating in this activity.